So in a regular spine surgery, the midline incision is down, and you can come closer so you can get a better picture here. And then we go down. This is spinal process, this is the facet, this is a transverse process. In a standard of care, which is a TLIF, transforaminal lumbar interbody fusion, we take the facet completely off. And if you want to come closer to get a better picture of it, so you see what the anatomical structures are, this is the facet that we take off to get access to the disc. The disc is then removed, replaced with a spacer, and then we usually put pedicle screws that go through the pedicle into the vertebral body, and posteriorly we stabilize it with a rod on both sides. In that process, the midline incision is done, the muscles are stripped. Those muscles traverse many levels up and down, so even if you do, for example, surgery on 3-4, we are destabilizing muscles that go from 3-4 leg segment to farther down and up. Now, in the regular direct lateral interbody fusion, which is the term that Medtronic use, and or OLLIF, which Nuvasive uses, patient is put to the side. We break the table, so literally back look like that for opening. The ribs are in this area. So, and we go directly down on the fluoroscopic imaging and perform a discectomy, put a cage in. Then this needs to be usually complemented with some sort of instrumentation, including turning the patient back, putting pedicle screws or facet screws, or the other possibilities are clamp or lateral plate, but the result of those has been very poor. I have seen many complications that the cage kicks out or fusion doesn't happen because if you don't do an additional 3-point fixation, what we call, meaning that spine is fixed and doesn't move, the result can be still unfavorable. There are some plates on the side that literally they have one screw. In that case, spine can still rotate around that one screw that on the lateral plate. And some people do unilateral instrumentation. That the result is not as good as a standard of care, which is a pedicle screw bilateral fusion. Now, in our OLLIF procedure, what we do is that we go obliquely, we go anterior to the transverse process through the retroperitoneal space, through the Cambine triangle, practically that area right there. And for many cases, this is just sufficient to get exposure to the disc base. And you have read the paper, and the papers are available, so you can get more detail from the paper that we published already. In many cases, if there's an anatomy there that is different, like severe anterolisthesis, when this bone is falling forward comparing to this bone, the anatomy doesn't give you a good Cambine triangle to approach. In that case, we could approach it laterally, directly from the side. As well, some insurance companies don't approve OLLIF. In those cases as well, we decide to go from the side. And additionally, in the OLLIF paper, at the beginning, we have to abort 5S1. And look at the 5S1 here. And look at the anatomy here. This is not unusual, a real anatomy of the patient. In the OLLIF, a true OLLIF, this would be the approach. And this is by iliac crest and ala of the sacrum. That approach can be very difficult. Now, after about a year doing OLLIF, we become much more successful doing OLLIF in the L5S1. And if we look at the technicality of it, mostly we weren't doing OLLIF. We were doing a direct lateral by bypassing the iliac crest and going, instead of Cambine triangle, directly to the space in the, and you can imagine that technically that's a very difficult approach, but we have been 100% successful in the last 2 years to do that. Well, only one case I had to convert about 1.5 years ago, but beyond that, this is actually what we have been doing. Most of our 5S1 are actually not the OLLIF, they are direct lateral. It is very interesting because the traditional DLIF, where you bend the patient on the side, is not made for 5S1. The traditional DLIF cannot be done for 5S1, whereas our version of DLIF can be done for 5S1 practically by us positioning the patient and going directly laterally to the L5S1 and getting the job done. Now, additionally, what's important is that in this, we just airplaning the patient back and forth for ease of access, but we are not completely taking the dressing off or the sterile drape off and repositioning the patient. Just that process would add about an hour to the surgery by taking all the drape off, reposition, redrape, and then restart the surgery from the lateral for the directly going to the disc base to posteriorly to do either facet or pedicle screw fixation. So that practically we have been almost as fast in our direct lateral as we are in our OLLIF, which is for one level is practically under an hour. The advantage of the way we do OLLIF is as well that we are doing over a tube system. With the bilateral fluoroscopic imaging, practically the setup is like OLLIF, so you can get the setup from the OLLIF. And all the instruments are practically the same. The neurophysiology that in the DLIF is done as well. We use when we go directly laterally, it's recommended to check the quadrant and make sure that there's no nerve in our approach. In the OLLIF, it's neurophysiology, it's the way we start anyway. So, and we get a much better reading by having a whole system available, and the probe that we are using is insulated up to the tip. Additionally, the lumbosacral plexus is here, and as you know, lumbosacral plexus starts at L1, and it just adds to it. The 4-5 has been in the regular DLIF extremely difficult because there are many nerves. When the lumbosacral plexus add to each other, there are more nerves going down. So 5S1 is practically in a regular DLIF impossible. 4-5 has been extremely difficult, and lots of nerve damage has been reported with 4-5 DLIF because the cage and approach is an open approach with a direct visualization, and it's a big cage that damage on the way going in the nerves. Our cage, the direct lateral, minimal invasive direct lateral cage that we use, is a conical shape that pushes the nerves out of its way, and practically it requires a much less footprint to get into the disc and then pushes the muscles away. So 4-5 OLLIF has been extremely successful, and 5S1, which is completely impossible in the direct lateral, is we do it every day practically, and that's what we are going to write a paper about. And if I would if I would literally put the if I would draw the nerves here, the nerves, they come, and the other nerves, they just add to it for the lumbosacral plexus. So by the time you get to the 4-5, there are many nerves that are in your way. That's why it makes the 4-5 so difficult for the direct lateral. In